موضوع رائع بيقابلنا مشاكل كتير جدا في شغلنا اليومي. فهو ان شاء الله هيخليه لنا يعني very easy and very palatable بطريقته الرائعه في الشرح. لكن احنا عندنا مفاجاه جميله جدا جدا، وان احنا معانا دكتور افاق نصيري، اختنا وحبيبتنا، يعني وبنت جلدتنا، وإن شاء الله رفيقة الدرب إلى نهايته بإذن الله. دكتور هيثم هيقدم دكتورة آفاق، لأنها لازم تقول لنا حديث جميل منها الآن، لأن إحنا هي الحقيقة هي اللي مش محتاجة السبورت بتاعنا، إحنا اللي محتاجينها الأكتر، واللي إحنا دي سعادة لينا وشرف لينا إن إحنا نكون معاها في أي حاجة. دكتور هيثم اتفضل حضرتك.
السلام عليكم ورحمة الله وبركاته. شكرا دكتورة صفاء على المقدمة الرائعة كالعادة. It's a great pleasure actually for joining this very honored gathering. And I'm حقيقة very excited to join this meeting, and I'm very excited as well about the nice idea that brought Dr. Afaq with us. It's actually science usually is not really devoted only for clinicians. Science is all about the people. I think it goes in parallel with all the morals and ethics that for what the ISAC has been really made for. وجود دكتورة صفاء دكتورة آفاق معانا الحقيقة في الظرف الحاضر يدل على our solidarity, our support for Morocco in general, for our colleagues, our brothers, our sisters in Morocco. وجودها تشريف لينا للإيساك، تشريف للجروب كله، تشريف للبانل، تشريف لكل الاتنديز. وجودها في واقع الأمر بيقول إن إحنا كلنا حابين المغرب وحاطين بيها. Heartfully we support the Morocco, we support our colleagues. I know that now all of the Moroccan doctors, whatever the type of their specialty, all of them now they are really working together hand in hand to ease the pain, to ease the catastrophe, to sort out the hardships. Here, Dr. Afaq is a representative for them coming with us here, and we are really shaking your hand strongly, heartfully, and gratefully, just to say we always, we still, and we will be with you. And it's up now, it's all to you now. Over to you, Dr. Afaq.
شكرا والله العظيم يعني دكتورة صفاء، والله العظيم يعني يعني تأثرت يعني حتى عشان أتكلم معكم. أنا في أول يعني أود أشكر الدكتورة صفاء يعني وأشيد باللي هي يعني بتعمله عشان الأنستيزيا والإنتنسيف كير يعني. وحقيقة يعني أنا ما أتبع يعني كل اللي بتعملوه في الإيزاك، والله العظيم يعني بشيد به وبشكركم بجميع اسم جميع الأطباء التخدير والعناية. يعني إحنا كمان في المغرب بنحاول نعمل نفس الشيء، وأنا متأكدة أننا لو عملنا إيد في إيد حيكون إن شاء الله عمل أحسن وأحسن، وهذا هو الأمل ديالنا في المستقبل إن شاء الله. والحقيقة يعني أنا مش مستغربة يعني يعني موقفكم ودعواتكم معنا وإحساسكم بينا، فإحنا في الأخير يعني وأنتم إخوتنا، وإحنا دائما عارفين إن إحنا العالم العربي والعالم الإسلامي يعني هو عالم واحد. وحتى لو تختلف اللهجات وتختلف كل واحد يمكن العادات ومشرقة ومغربة، ولكن في الأخير إحنا واحد، جسم واحد. ويعني لو تضرر منه طرف، الناس الأطراف الأخرى كلها بتكون موجودة عشان تدافع معاه. يعني في الحقيقة أنا تنشكركم كتير على هاد الفرصة اللي عطيتوني نتكلم، عشان نشكر الأطباء ونشكر يعني أنا جاني كتير سيبورت حتى من أطباء يعني مصريين ومن دول أخرى ما تنعرفهمش يعني. ودي حاجات اللي أثرت فينا كتير يعني، وحاسين أن الناس حاسين بهذا الهم اللي يعني إحنا حاملينه على الفئة. يعني للأسف الفئة اللي هي تعرضت للزلزال وفقدت منازلها، وبين ليل يعني بين نهار وليل يعني بين قوسين بقوا في الشارع. الحمد لله في مساعدات وفي يعني كتير من يعني عشان يعني يساعدوهم. فشكرا كتير لكم. يعني أنا هنا ما نطولش عشان يعني نبدا الويبينار. نقول كلمة واحدة، هو احنا يعني Society of Anesthesia and Intensive Care Analgesia and Intensive Care في المغرب موروكو، اللي هي الأسمار. فهي غدا تنظم، بنسميه تيليدون، يعني هي حتنظم مؤتمر هو علمي، وفي نفس الوقت يعني حيتكلموا الناس اللي هما كانوا يعني موجودين وساعدوا الناس وكيف يعني هما تصرفوا في هذه الواقعة. وحيكون يعني بنشجع الناس على أنهم يعملوا تبرعات للضحايا. تبرعات مش حنجمعها يعني احنا دايركت ولكن احنا يعني حنشجع ان الناس تعمل تبرعات للصندوق الوطني لمساعدة ضحايا الزلزال. ضحايا الزلزال. فانا حبعت لينك، وانا بعته في الجروب. ويعني لو كنتوا معنا وحد عاوز يتدخل ويقول لي يمكن يعمل مداخلة ويتكلم ويعبر على السبورت بتاعه، مرحبا بكم. شكرا كثير. شكرا دكتورة صفاء، شكرا لكم كاملين، ويعني شكرا من القلب. شكرا
جزيلا أفاق، شكرا جزيلا، نورتينا وشرفتينا، ويعني كل الدعم وكل الحب وكل التقدير لك ولكل إخواتي وإخواني في المغرب الشقيق.
شكرا
شكرا جزيلا
الله يحفظكم من كل شر ومن كل سوء يا رب.
شكرا دكتوره صفاء، الحقيقه يعني على الفكره الرائعه اللي طبعا دكتوره صفاء هي اللي الحقيقه جابت الفكره. ويعني الحقيقه انا كنت عباره عن منفذ. الحقيقه كانت فكره جميله، ويعني وفكره رائعه من الدكتوره افاق برضو انها يبقى في دعم، لان انا متاكد ان ناس كتير جدا حريصه جدا ان هي تبرز نفسها في موضوع الدعم ده، وانها تودي طريقه. وانا دايما بقول ان المغرب يعني الحمد لله مكتفي باهله، بقيادته، بشعبه، بكرم اهله. يعني انا مش عاوز احكي على حاجات كتير قوي، على ان الجاليات المغربيه في اوروبا وفي بريطانيا من اروع الجاليات، ومن اروع الناس اللي بيساعدوا حتى الشعوب الثانيه يعني. فده اقل شيء على فكره، يعني انا ده اللي عاوز اقوله، ده اقل شيء احنا ممكن نديكوا ورده من الزهور والحدائق اللي انتوا ياما نشرتوها في كل انحاء العالم الحقيقه. ده اقل شيء. انا اسف
انا
انا
عارفه
طولت، بس ده
لا
بس
خالص.
يعني
طبعا انا بس معلش الاسف انا قطعت حضرتك، بس انا علشان افاق معانا وانا عارفه انها على سفر، فهحاول كل الناس اللي موجودين دلوقتي، احنا حوالي 22 بارتيسيبنت، نفتح الكاميرات وناخد صوره تذكاريه مع افاق ان شاء الله. هي النهارده قد يكون بعض الالم او بعض الدمع موجود، لكن ان شاء الله بعد سنه متاكده ان ربنا سبحانه وتعالى هيخلي لنا الصوره ديت فرح وسعاده وامل وحاجات حلوه كتير، طول ما احنا ايدينا في ايدين بعض وكتفنا في كتف بعض ان شاء الله. فمن فضل كل الاتندي نفتح الكاميرات بتاعتنا بعد اذنكم، عشان ناخد صوره جماعيه لنا كلنا موجودين دلوقتي مع افاق ومع دكتور هيثم. كل يفتح الكاميرات بتاعتكم من فضلكم، من فضلكم كلنا. دكتور هيثم في النص كده واحنا حواليه. ايوه كده، ايوه كده، كلنا بعد اذنكم نفتح الكاميرات بتاعتنا ان شاء الله. ان شاء الله كل الم يختفي من حياتنا كلنا، وما يتبقاش عندنا الا الامل والسعاده، وكل الايام الحلوه نحتفل بيها يا رب. اللهم امين، اللهم امين،
اللهم امين.
اللهم يوسع الشيء شويه. كده اوكي. طب الباقي خدش الدكتور افاق لوحدها. لو يا جماعه اكبر عدد ممكن من فضلكم يقدر يفتح ممكن يكون في ستات قاعده من غير حجاب، فمعلش نلتمس لهم العذر، لكن
في
اكيد
حد يكون
الرجاله
مثلا
مش
يكون في
فارق
حد
معاهم.
بيطبخ مثلا او حاجه في
حد
المطبخ.
حد بيطبخ طبعا. كده ما فيش حد تاني مش كده؟ بس ياخدها بقى الصورة. بسطها. شكرا جزيلا دكتور هيثم لوقتك، وخدنا وقت مع حضرتك شويه.
لا
شكرا جزيلا
انا سعيد والله.
ربنا يخليك. شكرا جزيلا افاق، واتمنى لك السلامه والصحه وطول
آمين يا
العمر
رب.
والعافيه يا حبيبتي يا رب، اللهم امين. خليك
آمين
طمنين
آمين.
عليك ان شاء الله لما توصلي طريقك بالسلامه ان شاء الله.
ميوتد افاق.
يا مع السلامه. Really, it is an exceptional presentation, and for the second time, I expand my greeting and appreciation for my great colleague and friend, Dr. هيثم الجميل. ويومه جميل وطيب ومبارك إن شاء الله. اتفضل حضرتك.
الله يخليك يا فندم. Thank you, Dr. Safa, really for giving me this opportunity to be with your really respectable group and to share my ideas, share my slides now. And really, it's a great honor actually for me to always to be with Isaac. I can't really ignore the very, very, really robust efforts that have been conducted throughout the last couple of years in order just to keep this really a huge achievement rolling from 1 week to another. Probably it's a great honor for me to share some of my ideas, some of my presentation with you. Thank you so much for attending me, ladies and gentlemen. My presentation today is about the pulmonary hypertension and how we can just manage to make it easy. I mean, try to make it an easy subject, because everybody knows that pulmonary hypertension is slightly complicated in terms of not only of management of the pulmonary hypertension patient, but even throughout how we can try to figure out the boundaries of this treatment, the boundaries of the observation, the boundaries of the case itself. It might be challenging for our anesthetists, might be challenging for our junior anesthetists, not only on the basis of the cardiothoracic anesthesia, but even in non-cardiac patients as well. To start with, I will not really go through the physiology because I don't want to make it a little bit boring for everyone. So I think everybody knows that pulmonary vasculature is normally low pressure and low resistance circuit. So that means that actually literally that there is any kind of increase in the volume or increase in the pressure or the load in the right ventricle or in the pulmonary vasculature always cause a significant shooting up of the pulmonary blood pressure. It's definitely that represents a very challenge for all the anesthetists and might really associated with high mortality and morbidity, especially when those patients undergoing any type of stresses in the form of like surgery or anesthesia. And definitely you should expect that there is a long stay in the hospital and potential of staying in the ICU with other further potentialities or eventualities in the critical care. The pulmonary hypertension is classified whenever you have a mean pulmonary artery pressure of greater than 25 millimeter mercury at rest. And definitely it might be caused by a combination of factors that might really vary from vascular damage through the vascular proliferation, or a cause that might really resulted in vasoconstriction, extreme vasoconstriction, or if there is a kind of left heart disease that might really cause elevating of the pulmonary venous pressure, or in the states wherever you have a thrombosis or embolism, definitely this you should expect that the pulmonary artery pressure will shoot up. This classification will a WHO classification actually gives a very simple categorization for the pulmonary hypertension. Grade 1, whenever you have causes like idiopathic, hereditary, drug-induced, or in the case of the HIV, for instance, or in the case of portal hypertension like bilharziasis and similar diseases. Grade 2, whenever you have a left-sided heart failure. Let's say if you have a left ventricular dysfunction for any reason, ischemia, or maybe if you have a valvular problem, like anything in the left side of the heart, the left chamber, like if you have a pulmonary, if you have a mitral or aortic valve lesions. Going to the grade 3, which is mainly concise to the lung disease, or in the cases of the hypoxia, that simply if your patient have a patient with a severe form of the COPD, interstitial lung disease, or if there is an alveolar hypoventilation for any reason. Grade 4, whenever you have a chronic thromboembolic causes, like in it might really obstruct the right side outflow, or obstructs the pulmonary vasculature, like in the case of tumor or thromboembolism as well. It might be the more vigorous kind of like causes in this situation. Grade 5 is miscellaneous, simply if you have a hematological issue, like simply like sickle cell disease, or if you have a metabolic disease as well. Simply, we can go for the grades as well according to the measurements. So grade 1, which is considered the mild, whenever you have a systolic of 30 to 50 with a mean above 30. Grade 2, which is considered the moderate, when you have a systolic pulmonary artery pressure from 50 up to 70 with a mean above 40. Grade 3, which is considered the severe, whenever you have 70 up to 110, and just kindly notice that here you are almost approaching the systemic circulation, and definitely the mean here is above 50, and this is actually the main difference, because the mean in our normal systemic circulation definitely should be above 65, but here it's almost approaching down up to 50. Grade 4, which is suprasystemic, whenever you have a systolic pulmonary artery pressure above 110, and now the mean is almost approaching the mean arterial blood pressure. According to the severity, you can simply estimate the pulmonary hypertension, the severity, according to the estimated right ventricular systolic pressure. Normal, if it is above 35, mild, if it's from 35 up to 45, moderate, if it is 46 up to 60, and severe, if it is definitely exceeds more than 60. And you can definitely figure out all of that parameters by the aid of the echo, or the transthoracic echo, or even the transesophageal echo. And here, the symptoms varies according to the severity of the pulmonary hypertension. Let's say if you have a mild, if your patient has a mild pulmonary hypertension, definitely you will suffer from generalized fatigue, breathlessness, dyspnea on exertion. But whenever you have a severe, you should expect that the patient will have angina, syncopal episodes, dyspnea, even at rest, and definitely cyanosis and hypoxemia, which is maybe affected by other factors as well, especially if this patient had a right ventricular dysfunction. And you should expect that this patient always have a congested dick veins, tractate brugade, gallop, and might really be presented by pulmonary edema and peripheral edema, which actually one of the main and significant signs of severe heart failure. Okay. If you have an access to the transesophageal echo or transthoracic echo, you can check all these parameters simply. I'll make it simply here. We can check the peak tractate brigade velocity 2.8, if it is more than 2.8 meters per second. and there is a flattening of the IV septum. And simply, if you have an IVC diameter more than 21 millimeters, blunted inspiratory collapse, and the TAPSI. TAPSI means the tricuspid more than 1.7 centimeters. The TAPSI usually, if it's less than 1.7, that indicates that you have actually extensive right side heart failure and extensive increase in the pulmonary artery pressure. And here also we can bring more parameters that it shows if the patient is having what we call it the high probability pulmonary hypertension or not. And that actually brings that kind of terminology to our practice, because usually if you are dealing with those patients in the cardiac background, or like in the cardiac theater, definitely we will go, you have a patient, it will be definitely either black or white. There is no gray. There is no gray zone here. And the gray zone here means that the high probability pulmonary hypertension, and definitely that's actually those patients would be treated as a pulmonary hypertension or diagnosed as a pulmonary hypertension whenever they go for non-cardiac interventions. So the high probability pulmonary hypertension, there is a kind of consensus that as long as you have a TR or like a tracheal regurg velocity more than 3.4 millimeter per second, indicates the high probability of pulmonary hypertension. And if the peak TR velocity less than 3.4, this means probability could be assessed in combination with other echo markers. I'll try to move on the slide. Okay, I mean here, if you check the tracheal velocity, let's say, for instance, here, if it is more than 3.4 meter per second, considered there is a high probability, so you can treat this patient as a pulmonary hypertension. And if it is from 2.8 up to 3.4, so you should rely on other echo categories in order just to diagnose that. And definitely if it is less than 2.4, it is a low probability, so you can really manage according to your clinical assessment and according to the patient's clinical evaluation and according to his stability in the settings. The pulmonary hypertension here, there is some sort of additional marker. I will not go through actually all of that because it's purely cardiac background. But definitely we should consider also the ventricles. If you have a flattening of the IVC, this means actually the eccentric index are more than 1.1, and the flattening, if you can see that actually in the echo, that indicates really that you have a huge load stress on the right ventricle. Also check the pulmonary artery. Sorry, here. Let me. The pulmonary artery diameter, if it is more than 25 millimeters, that definitely indicates that there is actually a pressure or a volume overload. And if the IVC diameter as well, more than 21 millimeter, that indicates actually the high probability and definitely the severe form of the pulmonary hypertension, and definitely should expect that the right atrial area would be more than 18 centimeter 18, I mean the surface area will be more than 18 centimeter, which indicates actually that a huge really enlargement. And that's what actually been presented here in the form of increased right ventricular hypertrophy, and ultimately the patient will have one of the more significant eventualities, the patient will develop right ventricular dysfunction. Simply here you can look to how it looks whenever you have IVS or interventricular septum flattening. This means actually that the right side will push the left ventricle away, and that definitely will limit the cardiac output. And that's what the cause why we have a parameter that it might really it shows that your PA pressure or the pulmonary artery pressure will be very close to the systemic. This means actually that now you have a reverse circulation. The right ventricle is taking over now the load now, and now pushing more the LV, and that's why the patient will have more shunt and start to have a hypoxia and cyanosis. And this kind of right ventricular pressure overload, mainly during the systole. And TAPSE is very indicative for that, and definitely, as I mentioned before, if it's less than 1.5, this means an abnormal parameters. Look here, actually, this is a normal LV, which contracts very, very nicely, squeezing the volume and supporting the cardiac output. But here you can see this is the right ventricle, by the way, and pushing the left ventricle, and this actually the LV now, but actually by aggressively being concise, aggressively being compressed, and the atrial, IVS or the intraventricular septum became more flattened, and then that indicates that you have a significant reduction in the cardiac output. And this is also a more clear picture for the LV stress and the flattening of the IVS as well. Okay, let's go to the treatment, and definitely, and the treatment should really tackle many of the pathways that it might really affect the pulmonary vasoconstriction or vasodilatation or the vascular tone in the pulmonary vasculature in general. So simply, we need drugs that it helps either to relax the heart or to vasodilate the pulmonary vasculature. And if you vasodilate the pulmonary vasculature, simply you are causing reduction in the right ventricular afterload, and that would help definitely to the offload the right ventricle. We have the prostanoids, like simply the prostacyclins analog, which might cause a vasodilation, cause inhibition of the platelet aggregation. And the good example for that, and it's very commonly used in the market, is the IV epoprostenol and inhaled iloprost. And remember that in pulmonary hypertension now, we could rely on the inhaled form or even the IV form, and for some reason the inhaled is more effective as well. We have the prostacyclin IP receptor antagonist like Tilixibag oral, and this is oral, and this definitely could be used for the chronic use for those patients when you've been admitted in the hospital and have been discharged home. Probably you can keep them compliant or keep them prescribed to have the Tilixibag oral for the chronic use. Also, the endothelin receptor antagonist, and which helps actually to prevent the blood vessel narrowing, causing the vasodilatation, have some anti-inflammatory properties. And the most common really used drug is bosentan and ambrisentan as well. Calcium channel blocker is really very, very reputable in relaxing the heart muscles. Simply, everybody knows the imilodipine, the daltiazem, nifedipine. Also, the famous phosphodiesterase inhibitors, including the sildenafil and tadalafil, and just very famous, definitely the market. And definitely it helps to clear the blood vessels in the lung, and helps also to maintain a significant pulmonary vasodilation as well. And there's other forms as well of sildenafil that it could be presented in the market as an IV form, which now, I mean, for maybe since like maybe 3 or 5 years becomes available in most of the ITUs now for the patients, just only for the emergency use. Along definitely with the milrinone and amrinone, which helps actually to reduce the right ventricular afterload as well. Part of the treatment should really maintain the inotropic effect of the heart. So by using the inotropes like digoxin, and it helps also prevent arrhythmias, which is really could be fatal with those patients. New Kids on the Block has been presented to the market a couple of years ago, and now it's been really very famous and very reputable in most of the centers around the world as well, is using the DABA or the dapagliflozin. It's a diuretic, by the way. They discovered this kind of inhibitors. It's an SGLT2 inhibitors, and it's mainly an anti-diabetic drug. But they discovered that it actually have a significant and prominent diuretic activity, which helps actually to attenuate the high right ventricular systolic pressure failure, and it helps also to act as a diuretic, as really a potent diuretic in the cases of right side heart failure, and it helps actually to reduce also the right ventricular afterload, and helps actually to decline the stresses that it might really provoked by the high volumes that might cause increase in the pulmonary artery pressure in general. Don't forget that anticoagulants might be used as well, and that definitely prevents the thromboembolic. So it helps for grade 3 and category 3 and 4 as well, by using the warfarin or any other anticoagulants as well. The use of diuretics definitely is very important because it decreases the preload, avoid the fluid retention, and simply it is one of the basic pillars for the treatment of any type of right side heart failure. Nitric oxide, maybe it's more specific actually to use nitric oxide in those patients because simply it's because a significant and it causes actually a very prominent pulmonary vasodilatation and stimulates the guanylyl cyclase as well. And it's inhaled drug, okay? And it's very famous actually. It's very famous in this setting as well. In this setting, especially when you try to treat the pulmonary hypertension, it's all bounded together. Whenever you have a patient with a pulmonary hypertension or right side heart failure, the first thing that comes in your mind, especially in the critical care settings, is the nitric oxide. Other cyclic guanylyl cyclase agonist enzymes like glucoceguar relax the pulmonary artery, and definitely it could be supportive, and it work in parallel with the nitric oxide. So it might lead, might estimate the effect of the nitric oxide, might really cause more potentiation to the effect. And if you can use both, definitely in the nitric oxide, that will definitely help you later on to reduce the doses of the nitric oxide and slightly will avoid the toxic, as we're going to discuss later on. If you fail, maybe vasopressin could be really a very good choice, but I think it may definitely in the late stage because although that it might cause flanking vasoconstriction, but actually it could have significant pulmonary vasodilation as well. Nitric oxide could be the miracle molecule. Why? Because it's mainly acts on many levels. Simply acts on the cellular level because it causes pulmonary vasodilatation, inhibit the platelet aggregation, and have properties toward inflammatory reaction, especially in the cellular level, and it helps actually to improve the immune response, and it's been tried and have a very good reputation during the coronavirus, during the COVID as well. But on the cardiopulmonary level, it's a selective pulmonary vasodilator, and definitely, consequently, it causes reduction in the right ventricular afterload. It helps to reduce the right ventricular failure, and definitely it's a kind of rescue measure in the case of right ventricular dysfunction, and especially could be used effectively and efficiently in type 3 pulmonary hypertension if the patient has ARDS or hypoxia or COPD or any kind of lung category. As I mentioned before, there's some sort of anesthetic, there's some sort of anesthetic challenges in form of those patients actually usually lies under the surgical stress and exacerbations of the pulmonary hypertension. They might easily develop some arrhythmia inside because of those stresses as well inside the operating theater. They are struggling to maintain an adequate cardiac output, so they have, because of the congestive heart failure, definitely you should expect that they might have a syncopal attack or angina. This means that they have myocardial ischemia due to the LV and RV hypertrophy. Also, we should expect that they have a long stay in the ITU with a delayed extubation, prolonged ventilation, with a hemodynamic instability. Cost-wise, it's a catastrophe. However, the choice of anesthetics always is really quite challenging as well for those patients. So you should choose between going to the regional anesthesia or the general anesthesia, and definitely the choice depends mainly on the type of procedure. So if you have, let's say, simply, if you have a lower limb procedure like hip, knee, or foot, ankle, if you have the potential, if you have flexibility, if you have any kind of accessibility, or if you have the choice to choose the regional anesthesia, definitely you should go for the regional anesthesia. It's much better for you, for us, for everyone. Okay, and definitely that will be helpful as well for the post-operative pain control. But let's say if you need to consider other types of surgery where the the choice of regional anesthesia is very limited. It's very really is very concise. Probably you should think about general anesthesia, especially if you have a long surgery and if you're expecting that the patients with the regional anesthesia might be cooperative with you for any reason, if you cannot lie flat for a long time, definitely that general anesthesia could be considered, but definitely it actually carries a lot of risks as well in these settings. And here, you should consider the preoperative conditioning. If you decided to go with the general anesthesia, and between me and you, even for the regional anesthesia, you should consider all these things as well. So first of all, a few things, quite few things you should emphasize on. You should ensure that it will be maintained, like the improving the oxygenation, maintaining high FiO2, maintaining permissive hypocapnia with a CO2 between 30 to 35, maintaining a slight permissive alkalosis, optimal ventilatory volumes, usually go with the low tidal volumes, and certain things needs to be certainly avoided, like hypoxemia, high inspiratory pressure above 30 millimeter mercury, high PEEP if it exceeds more than 10 to 15, hypercapnia, acidosis, or all the histamine releases, all the drugs that might cause histamine release, definitely it might cause a significant increase in the pulmonary artery pressure. And anything could increase the peak airway pressure or the mean airway pressure. Now you are in a safe situation to apply. Let's say if you have to choose the general anesthesia, and now you have to try to tweak things in a way that you can get the perfect settings, the super settings, in order to maintain adequate ventilatory strategies, adequate ventilatory adequate strategy that much helps actually to maintain your patient without having exacerbations of pulmonary artery pressure. So use the volatile inhaled anesthetics. Definitely it's a good choice. Using low tidal volume, less than 6 ml per kg, maintaining the peak inspiratory pressure or the peak airway pressure less than 30 millimeter mercury, maintaining the high FiO2, maintaining a low PEEP, but most importantly as well is you should consider using the pressure controlled ventilation rather than volume controlled ventilation, especially in the severe and moderate to severe pulmonary artery pressure. The reason why we should actually be considered a low PEEP usually is because it might really compromise the preload very significantly and might cause systemic hypotension, especially in the severe form of the pulmonary hypertension. Monitors, usually, if you have facility to put the TOE, definitely it's actually an excellent choice. PA pressure catheter or Swan-Ganz catheter, it became, to be honest, a very old-fashioned type of monitor, especially if you need to monitor the patient at the ITU. I would say that there is a lot of monitors now being in the market, like the pulse contour analysis monitor. Definitely, it much really gives you can retrieve the same parameters without really exposing yourself and your patient to the risk of maintaining the pulmonary artery catheter for a long time, especially if the patient is in severe pulmonary hypertension, or if you don't have a very well-trained staff in the ITU or in the cardiac ICU or in the critical care to use the pulmonary artery catheter or the Swan-Ganz. So the pulse control analysis, as I mentioned, could really give you a good parameter without exposing the patient to the risk of having a catheter for a long time. Here, if you decide to go with the one lung ventilation for any reason, using the double lumen tube, better to avoid. Okay, why? Because definitely, if you have reduction in the blood flow, the non-ventilated lung, I mean, the non-ventilated might be the upper lung or the surgical lung, that much really helps to, or maybe causes an acute exacerbation of the pulmonary hypertension, and might, especially because of the hypoxic pulmonary vasoconstriction, which is one of the compensatory mechanisms that much really been evolved during the situation, during the procedure, whenever you try to apply the one lung ventilation or the double lumen tube. And definitely that might really increase the right-sided heart failure by increasing the afterload on the right side, and that definitely will affect and exacerbate more pulmonary hypertension. So if you could avoid this setting, probably be much better. let's say, hopefully we manage actually to treat the patient adequately and properly in this theater, and now we'll go to the post-operative critical care management. And here, you should consider I don't have really a quite very clear number about the percentage of patients that might really require nitric oxide post-operative, but definitely it is really a significant number, especially if the patient pre-operatively is being treated with a huge number of drugs, of the patient is in a severe pulmonary hypertension. But usually, this is one of the main potentialities, one of the main eventualities that the patient might need nitric oxide post-operatively. And that's what shows actually here, I mean, how we can connect the nitric oxide. It could be connected to your ventilator here, and the patient is there, and definitely there is a quite few parameters needs to be put in consideration in order to maintain that. And the main thing here is the dose of the nitric oxide. Let's be very simple. The dose usually should never exceed more than 20 ppm part per million. By the way, 10 ppm, if you could, might be so sufficient for you. So from 10 to 20, you're still in the green side of the garden. But if you went beyond the 20, now you are really crossing the fence and you are crossing the boundaries, and you start to put yourself in a situation that you should expect that there is some sort of side effects or some sort of toxicity observation might appears. And actually should evaluate the benefit risk outweighed actually about what you can get from higher doses as well. And there is some expectation that the treatment with this nitric oxide with 20 ppm might really goes beyond even 2 weeks, around 2 weeks, until you manage actually to have a significant resolving or significant improvement. You can sort out your desatting. But definitely, whenever you try the nitric oxide, the delivery system, the ventilator, should be usually and precisely calibrated, and you should be monitored as well. An evaluation of the treatment should be done every hour. Let's say every hour, half to 1 hour, according to your facility. And example for that, let's say if you have an increment in the incremental increase in the PaO2 by 20 millimeter mercury, that actually indicates that you have a complete response for the inhaled nitric oxide. So no, you start now to wean down the dose, let's say from 20 ppm down to 18 ppm or 15 ppm, let's say. Partially, you might really have to stay there. You don't have to go up above, let's say if you start with the 10 ppm, so no need to go up because you have a partial improvement if you have an improvement in the PaO2 by 10 to 20. But if the saturation increased also above the 10%, this means you have a complete response or a complete improvement. Between 5 to 10, this is partial. If you are able, actually, if you have an accessibility that to wean down the FiO2 down by 0.2, this means actually you are having a significant response and positive response to the inhaled nitric oxide. But above 20, and for a long use of nitric oxide, you should expect really many side effects. Simply, the methemoglobinemia could be fatal if it is more than 5%. The development and the formation of nitric dioxide, which is really very toxic as well. You should expect that this patient might have a rebound pulmonary vasoconstriction, especially if the nitric oxide being discontinued after chronic use. So expect that this patient will have a pulmonary vasoconstriction as well. Platelet inhibition, especially if the patient having a thrombocytopenia or a bleeding. And you should consider as well that inhaled nitric oxide have a free radical probability and to have a more tissue damage. Theoretically, it might really damage the lung and cause lipid initiation of the lipid peroxidase enzymes, and that actually, if it's been transferred to the neural tissue, it might really start to have a glutamate neurotoxicity and might cause a neurodegenerative disorders in the form of strokes, epilepsy, Alzheimer's on the long run, lateral sclerosis, simply because it can cross the blood-brain barrier. It might really cause accumulation, which might cause a neurological insult as well. So finally, we should consider also the surgical treatment, but definitely if all the above maneuvers, of all the above measures, of all the above medications and interventions fail, you should be, sometimes we transfer this patient to a specialized center in the management of the right ventricular failure or in the pulmonary hypertension. There's specific centers there to start really schedule this patient for atrial septotomy, creating a kind of a hole between the IAS, so it goes a vent that it might really release slightly part of the pressure, or a lung heart transplant could be an option as well. I came to the end here, and the take-home message here, although that definitely we might really provoke more efforts toward the treatment of this patient, and you might really do your best effort, but still you should expect that those patients really might really chronic patients, and you still expect that you will not be able to cure them completely. So you should expect complication in the form of the right side heart failure. And as I think most of us, most of you know as well, that if the patient have a right heart failure, and it's very, and it doesn't matter how hard you try, the right side heart failure is irreversible. You need just only to maintain the patient stable. And if the patient have arrhythmias or systemic hypotension, it much really ends by death. It could be fatal for them. The anesthetologist usually should have the ability, should have really the ambitious. It should be ambitious to avoid the exacerbating factor, but not curing the pulmonary hypertension. You will avoid the exacerbating factors, trying to control beta as much as you can, and do all of your efforts in order to get this patient to achieve the best perioperative outcome. However, the things need to be optimized here: the blood pressure, the cardiac output, the O2, the oxygenation, the fluid. The fluid management for those patients is quite challenging as well. The pH status is really very important. You can play with the ventilator status in order to maintain an appropriate pulmonary peak airway pressure, mean airway pressure, and you should really maintain all these parameters in order just to ensure that this patient will not really have an exacerbation of the pulmonary hypertension. That's all for me, and thank you so much for attending my presentation, and thank you so much for listening. And definitely, I'll be great. Actually, if you have any question, I'll be very delighted actually to answer all the questions. Thank you so much, Dr. Asfa.
Thank you, Dr. Haytham, for this distinguished lecture and amazing presentation. So anyone of the floor have any question, please? Yes, we know that it's more than excellent presentation, but you should have questions to have more expansion of your knowledge and the practical experience. This is one of our hard, stony issue during our daily practice. So anyone have any question, please? So دكتور موفق حضرتك موجود معانا؟ Anyone have a question? So may I have question, Dr. Haytham?
Yes, definitely. Absolutely.
During my daily practice as an obstetric anesthesiologist, So I should stop my question as we have a question from the floor, and I will ask my question from Dr. Muhammad. Is ECMO has any role in management of pulmonary hypertension? This from
Well, that's a nice, really, thank you, Dr. Muhammad. That's such a nice question. I was expecting that, actually. And let me tell you something, Dr. Safa. Really, the more you rely on the other parameters, I mean, and the other interventions in the pulmonary hypertension, the more you realize actually that those patients are really very critical. ECMO could mean with this situation that this patient is almost in need for heart transplant. Because for how long you keep the ECMO, you keep this patient on ECMO. ECMO really is a quite really challenging intervention. It would never treat the pulmonary hypertension. It might really helps to relax the heart, relax the right ventricular failure, which is very challenging. Right ventricular, as I mentioned, right ventricular failure is really irreversible. It is really critical for those patients. So if the pulmonary hypertension cause a right ventricular failure for any reason, and the patient reach the ECMO, this means literally that the patient needs heart transplant at the end. You will not really able to keep the ECMO for a long time. So it's a kind of a bridging intervention until you book this patient for heart lung transplant.
Yes, the second question from Dr. Muhammad also is about lung biopsy, and we will shift to Sam Sultan. He is my colleague and my son in the same time. He is an assistant professor of anesthesiology in Menofia University. So completing the question of Dr. Muhammad about the pulmonary biopsy or lung biopsy for grading the staging of pulmonary hypertension.
Why you need a biopsy for that? I mean, you have other symbol. I mean, thank you so much for the question. Really, it's a very nice. I mean, just but actually, I mean, it's going to be difficult actually to tell the patient, convince the patient that you need to take a lung biopsy in order just to diagnose it. It will never. I mean, make any difference as long as you have any maneuvers, or let's say, and you have interventions which is quite really less invasive in order to do a grading for the pulmonary blood pressure. It would be more than enough. You can do that by the transthoracic echo. You can book the patient for the transesophageal echo. You can really get the parameter, retrieve the parameter, then you do the grading regardless the type of the cause. It would never make a difference actually to have, I mean, to know that category 1 or WHO 1, grade 1 or 2 or 3. What I need to know if it has a mild, moderate, severe, or suprasystemic. That's actually what makes me concerned. But thank you so much for the question, Ray.
يعني رزق حضرتك كتير، عندنا questions كتير. So I promise all my colleague and my attendees that you will have a full chance for your questions to be answered. But please, because we have a huge amount of questions, let me by sequences try to deliver it to my great friend, Dr. Haytham. So we have now Sam Sultan.
السلام عليكم.
وعليكم السلام دكتور وسام.
ازيك؟
دكتور هيثم، دكتورة صفاء، ازي حضرتك؟
الله يبارك فيك
دكتورة صفاء.
والله
دكتور وسام.
شرف لينا والله دكتور.
يعني لا، الشرف ليا والله.
ربنا يخليك. وسام انت فريزد انت فريزد. شوف انت ايه اللي حصل في النت عندك. You are freezed now, وسام. Sam. So Sam, excuse me, you are not in contact with us.
طب كده الو.
تمام.
ايوه الو. السلام عليكم. الو. It's okay now?
Yeah, is it
Yeah, it's great.
Okay. Dr. Haytham, I have a couple of questions. First, as far as I know, and
after
as
the
far
first
as...
one, it will be paid, Wissam. After the first one, it will be paid.
Okay.
Yeah, we have offer today. You can get a 2 and 1 for
an extra 1 free.
Yeah.
free.
Okay.
Okay. As far as I know, and as far you mentioned, Dr. Haytham, that the pulmonary hypertension not a curable disease. So if I face the patient for elective surgery, and in the echo I found that the patient had severe pulmonary hypertension. For example, the pulmonary systolic pressure is 60 millimeter mercury, and the patient is compensated, not complaining of anything. Should I push directly to the OR, or should I give him first chance for medication for 1 or 2 weeks or whatever?
And thank you. I mean, that's actually an awesome question. Thank you for that kind of thing, because this is a very common question. I've been asked the same thing, actually, not all, by the way, not only in Egypt, everywhere around the world. Okay, so well, let's say if you feel that this patient is elective and his condition actually is not really emphasizing that this patient will die, and that shows, I mean, that will reflect that this patient might really die if he waited for another 1 or 2 weeks. You can wait, okay, if it's an elective.
Yes.
But let's say, actually, that will take us to another question. And
what is my target?
Sorry, yes. Ongoing. There is an ongoing. Yeah. Okay. Now it's. I think it's been muted now. No worries. Yeah. Yes. Over to you, Mr. Dr. Wissam. Over to you. Yeah.
Yeah. So if I postponed him for 2 weeks, what would be my target?
Excellent. So the reason, actually, this patient will never really have a quite improvement for his parameters. So you don't expect, actually, and that's what actually very common mistake that have been really wrangling throughout the. I mean, most of the other non-cardiac theaters. They think that if they keep the patient for another 2 or 3 weeks, maybe the patient will get an improvement, and then rather than being a pulmonary artery pressure of 60, he will get like a 55. It doesn't make any difference if the.
Yes.
60 to 55 or even 45, it doesn't make any difference. And that's actually not really a guard against the occurrence of those kind of exacerbations inside the theater. But the reason why you should wait, first of all, if there is any potential of right ventricular heart failure, definitely if those patients, let's say if we have a severe pulmonary hypertension, they have any kind of congested neck veins overloaded with fluids, you might really start to ensure that this patient have a lot of medications that might really optimize the preload, optimize the afterload, giving the patient more diuretics, make sure that the patient will not develop any kind of arrhythmias, make sure that the patient don't have any kind of electrolyte disturbances or acid-base disturbances. Make sure that this patient, if it goes in the ventilator for any reason, remains for a long time, he will never have any kind of pulmonary edema, and it might really have a prolonged post-operative stay. So this kind of optimization or a kind of preconditioning, it might help you during the procedure, but definitely it will never, and again, it will never ever improve the pulmonary pre-existing or the existing.
Yes, the figures. It will not improve the figures. The figures
just
still
to
the same.
Manipulate. Yes, I hope I understand well. It's just to manipulate the comorbidities that may aggravate if he has blood sugar more than 150, has some sort of viral infection, some sort of arrhythmias, etc.
Pulmonary edema, the lower level edema, right ventricular stresses.
Yes, if he is a heavy smoker and should stop smoking. So any contributing factor that aggravate the condition intraoperatively, we should abolish it within these
just
to
optimize the condition. That's
exactly.
Yes. So have all your weapons ready.
Yes, nice. Okay.
Yes.
My second question. You said that regional anesthesia might be preferable over general anesthesia in such situation or some situations.
In some particular conditions,
yes. So even including the neuroaxial blocks or just the regional nerve blocks, peripheral nerve
No,
blocks?
including definitely the neuroaxial block. And this is actually an amazing question. Thank you so much. But believe me, if you want to do, even if you're going to do with spinal anesthesia for those patients, you should really put arterial line, awake arterial line. If you could put awake central line and give them spinal. That's what I usually do with the severe patients. So you treat them because definitely spinal anesthesia could be an option actually for the say hip surgery, knee surgeries, or whatever. But still, you need just to apply really a very good invasive, a bundle of invasive monitor with those patients. And now you can just deal with the patient as if it is a general anesthesia, but the patient is awake with you.
Yes, Wissam.
Yeah.
Very nice, very nice.
Okay.
Okay, Wissam, do you have another question?
Yes, my last question.
Yes.
In case of if such a patient developed hypotension, what is the proper vasopressors could be used in such situations?
What you already have in your theater, Dr. Wissam?
Yes, I have ephedrine, I have levofed, I have adrenaline, I have that's what I have.
Excellent. So,
no more.
Well, I would say that the best option is if you could have a phenylephrine or metronidazole.
Actually, we don't have. Yeah, we actually in Egypt we don't have such this group of medications.
Okay.
So in case of if I have just these three only drugs.
Definitely, if you have a central line, you can start noradrenaline.
NORAD.
Yeah, NORAD. Yeah. Start NORAD. But definitely, but I mean, usually, I mean, simply, I mean, let's say, rather than starting really, it's a tips and tricks, okay? Rather than actually, let's say if the patient have a broken wrist for any reason, it's a very simple procedure. I mean, it make no sense actually to put a central line for those patients. So I would say that if you can secure a wide bore IV and run a metronidazole infusion or a phenylephrine, that's the reason why I'm asking about the vasopressors. Because as long as you can run a phenylephrine infusion or a metronidazole infusion, definitely it will much help you to support the blood pressure without the dire need for central line to run the NORAD.
Yeah.
Yes.
But you know, NORAD nowadays, I think we can run it in the peripheral line, but just in small doses.
Yeah, okay.
Can be in such in the emergency.
Could be in emergency. A lot of things actually has been allowed. Okay, but I mean, but as long as you have let's say I have a facility if you have a facility for like any other vasopressor like a phenylephrine or the metronidazole, probably it might really be very helpful. By the way, ephedrine could be a good choice as well, but the problem is you can't run. You usually rely on boluses, so you give more boluses, but it might really cause the tachycardia. So if the patient has arrhythmias, probably the ephedrine you found actually a very significant sign. Better to avoid the ephedrine, definitely, unless if the patient having a bradycardia. So this is a point actually when you use the ephedrine would be a very good choice in those patients.
Dr. Haitham, thank you very much for your.
It's a pleasure, always a pleasure, Dr. Wissam, to meet you and to get your questions. And really, it's delighted actually to see you.
Thank you, Wissam, for your fruitful and amazing question and for always your valuable contribution.
Thank you for enriching the floor with your questions. Thank you so much.
Yes, thank you. We have Kevin Omani. He was the organizer of Kenya conference this year. He is one of my great sons. Kevin, where are you? Kevin, where are you, my dear? I should unmute you. Kevin.
Yes, hello. Yeah.
Are you in Mombasa, Kevin? Are you in Mombasa yet?
No, I'm in Nairobi. Thank you.
I've enjoyed. Yes. So we are ready for your question.
Thank you for this meeting. I appreciate the
Dr.
speaker.
Haitham Kevin is one of the highly specialized one in Kenya in cardiothoracic anesthesia, and he will deliver his speech now. Okay, Kevin.
Hi, bro.
Thank you very much for your talk. My question is, if you find an echo showing you that the PA pressure is near systemic, is this child a better candidate for regional anesthesia rather than general, considering that there's risk of a pulmonary hypertensive crisis with surgical stimulation? So I wanted to hear your thoughts if you see on an echo, because last week there was a child we had who has a PDA and it is a left to right shunt, but the PA pressure is near systemic. And I advised that general anesthesia is not the best for this child, probably would benefit from a regional block.
Yeah,
it's a shoulder. It was a septic arthritis on the shoulder. So we're thinking of a supraclavicular block with some local infiltration in the child. So I was wondering what would be your thoughts in such a patient where the PA pressure is near systemic when you see that on echo?
Well, can I ask you? Thank you so much, really, Kevin. That's such a really a very actually a very nice question, and I'm impressed actually with the way that you are really organizing the details as well. But can I ask you about the child's age, please?
This child was is about 4 months of age.
Good. So the regional anesthesia can't control the child now. So it's hard to control the child on the table. I would say that now, even if it is severe and if it's even systemic, probably this child should have both regional anesthesia and general anesthesia as well. If you can just stick an laryngeal mask, like the form of the iGel, Supreme LMA, or any type of LMA, okay? And just put him off to sleep and reduce the, let's say, the anesthetic requirements by giving the regional anesthesia. Definitely this will be the best choice for you, because let's to be realistic, just to be really actually I think it will make sense to say that you can't really rely on the regional anesthesia with this baby. You need just to keep him actually very well controlled on the table. You need to just to keep him still at the table. So you need a general anesthesia. So give the general anesthesia from the beginning, using the inhalation anesthetics, use the LMA if you wish, give the local blocks and regional blocks, whatever you have, whatever you can do, okay? And then I think that patient will be very stable with you.
Okay, all right, thank you. Okay, thank you very much.
Always a pleasure.
We have a question from Ghada. Ghada, you still raising your hand, Ghada? You have a question? Ghada? Ghada? Ghada, where are you?
أيوة السلام عليكم.
عليكم السلام.
أنا الدكتور أيمن عبد العزيز. أنا بس بحيي صديقي الدكتور هيثم وبحيي حضرتك الدكتورة.
دكتور أيمن عبد العزيز أستاذي. ماي برو.
هو الاسم ظاهر غادة، بعد إذن حضرتك
معلش
الأكاونت سامحني
دكتور أيمن عبد العزيز الحقيقة طبعاً. يعني راجل إنسان عظيم.
الله يخليك
ولا أنكر فضله عليا في حاجات كتيرة جدا جدا جدا. الحقيقة أنا فخور جدا إن أنا سمعت صوته والله.
يعني أنا استمتعت بالمحاضرة الجميلة بتاعتك يا هيثم، واستمتعت أكتر إني شفتك
دكتور أيمن.
شكرا دكتورة صفاء على إتاحة الفرص دي إن إحنا نشوف الناس الكويسة دي.
الله يخليك دكتور أيمن.
حضرتك شرفتنا.
الله يخليك، بالتوفيق إن شاء الله.
نتكلم.
شكرا
حبيبي يا دكتور أيمن، الله يبارك فيك. حبيبي يا دكتور أيمن. الله يخليك. ألف سلامة. ألف سلامة. ألف سلامة.
So we have a question from Dia about the fluid status monitoring in pulmonary hypertension?
Oh, yeah. So, as I mentioned, one of the main reasons why the people actually came up with the idea of using the pulmonary artery catheter in those patients is to how to tailor your tailor your fluid status according to the patient's need, according to the right ventricular afterload, and avoid any kind of any kind of background overload for those patients. But as I mentioned, if you have a potential to use the pulse contour analysis, like in the form of like Latico, Vigileo, PECO, HBI monitor, you can rely on it. You can rely on any monitor that can gives you an impression about the SVB, SVI, or the cardiac index, rather than using the pulmonary artery catheter. I mean, if you don't want to use it, if you don't have a facility to use it, if you don't have enough experience with it, if you are afraid about your patient potentialities or like eventualities in the ITU, so you can rely on other monitors like a FlowCat or, as I mentioned, the Vigileo. That will definitely be very helpful with those patients.
Yes, yes. We have a question from I don't know really, but it's abbreviated as WI. Does the use of Edwards machine give different variants if connected to arterial cannula rather than CVB during the surgery in patient with pulmonary hypertension?
Can I ask you to repeat the question again, Dr. Safa? I'm sorry.
Does the use of Edwards machine give different variants if connected to arterial cannula rather than CVB during the surgery in patient with pulmonary hypertension?
That's what I mentioned, actually. Any pulse contour analysis with the, I don't want actually I don't want to be biased or to declare no conflict of interest. So I will not really mention the company, because Edwards, I mean, anyway, but everybody knows that Edwards usually have their own Vigileo. They have, I mean, PECO, Latico, or whatever, or currently the HBI as well. But any type of pulse contour analysis, monitor, if it's been connected, if you can retrieve the CVB, you can retrieve the arterial wave from those patients and use, I mean, those parameters that can be retrieved. You can monitor the patient SVB fluid status, and you can rely mainly on those parameters to tailor your fluid management for this patient and even your tropes as well.
Yeah, we have a question from Hanadi. Hanadi is a lecturer of critical care in Monofia University. She asked about the usage of nitric oxide by conventional ventilator or need a special one.
Honestly, I'm not really very familiar with how they can board it, because usually the nitric oxide could be connected the CBU. I mean, it comes to the tower like CBU using tanks, and it could be connected to any type of ventilator. That's what actually, as far as I'm concerned, as far as I'm aware. Okay, but definitely, I'm not sure if you have the type of the monitor. The type of the ventilator that you need in order just to connect your nitric oxide will be compatible with your existing CBU or the nitric oxide unit. Definitely, you need to ask the biomed or the bioengineer, because they have their own particular tricks in order just to they can maintain actually a very good attachment to make sure that the attachment will goes really tightly. Because remember, if there is with the wrong attachment and if there is a leak, it might be really very toxic for all the personnel. That's why what I recommend, or I actually strongly recommend, if you need to start the nitric oxide inside the theater, like in some centers, probably we call the bioengineer, we call the RT or the respiratory technician, because they have really acquired a very good experience with this kind of attachments, and they can tell you exactly. I mean, if you need a further things need to be attached in order to ensure the sealing of the whole circuit.
The same question also, if there is a protocol to guide us to start nitric oxide in ICU, or it depends.
Well, you mean the protocol for the doses, or regarding the patient's condition?
Yes. Hanadi, are you here, Hanadi? Hanadi, she is the one to ask the question. Hanadi.
Hanadi, unmute yourself.
Hanadi, are you here, Hanadi? They may ask about the start of the drug.
Yes,
not the dose, the start of nitric oxide.
Oh, okay.
Yes.
Got
Yes.
that. Okay, so initially, as I mentioned, start with usually depends on the patient condition. So let me just keep it very simple and clear as well. Let's say if I know from the beginning that the patient's having a severe pulmonary hypertension, this means actually I could start with a 10, aiming up to 20 ppm, and according to the response for my management or for my intervention with the nitric oxide, probably that might really affects the way that I can go up from 10 up to 15 and then up to 20. Some of the patients, if I know from the beginning that actually you have a suprasystemic, this means definitely it's a waste of time to start with a 10 ppm. So I start with a 20 from the beginning and start really to wean down. Okay, and according to the response, and as I mentioned, the response means improvement at the PaO2. Okay, that's what I mentioned actually in my presentation as well. If you have you have either a complete improvement or a partial improvement. Complete improvement means an improvement in the PaO2 or oxygen tension by more than 20 millimeter mercury. If it is 10 to 20, this is a partial. So stay as you are. But if you have at the 20, then you start really to decline or start to wean down. Also, improvement of the saturation by 10%. Also, there is reduction in the FiO2 requirements. So rather than relying on 100%, you start really to come down by down to 90% or say 80%. This means that you have a resolving for the desaturation, and this means that you start now to reduce your nitric oxide according to the patient response and according to the improvement of the oxygen desaturation. So you rely mainly on the, as I mentioned, to summarize, PaO2, FiO2, and also the beep, and definitely the saturation as well. So the beep, if he is on 10 or 15, and you start now to find an improvement in the saturation, and you can come down with the beep down to 10 millimeter mercury. This means literally that this patient is having improvement, and then you can come down with the nitric oxide accordingly.
Yes. Hanadi, are you here, Hanadi?
يا دكتورة حضرتك سامعاني؟ بشكر الدكتور على المحاضرة الرائعة، يعني محاضرة جميلة جدا. أنا اسمحوا لي هتكلم عربي علشان أعرف أسأل السؤال بتاعي مظبوط. أنا يا دكتور هيثم، حضرتك يعني هل في حالات فعلا أنا مش يعني إحنا بتقابلنا حالات كتيرة بالمونري هايبرتنشن، وممكن تبقى في الرعاية البلمونري هايبرتنشن عالي جدا، ممكن 70 و80، بس انا ما شفتش ولا حاله مره فكرنا ان احنا نطلب لها نيتريك اوكسيد. فانا عايزه اشوف هل ده فعلا ابليكابل ومتاح، ولا يعني هي امكانيات، ولا هي اكتر ليميتيشن في اليوز بتاع النيتريك اوكسيد؟
طيب، سؤال حلو. اوكي، سؤال جميل. هو والاجابه الدبلوماسيه ان انا اقول هو ميكس بين الاثنين، بس انا مش هقول لك الاجابه الدبلوماسيه. خلاص. I will tell you something. If you try, I mean, if you could try to improve the patient without the need of nitric oxide, you'll be really a very good clinician. As simple as that. Okay. As I mentioned, those patients, as I mentioned before, those patients will never have a significant improvement in their pulmonary artery pressure. I mean, those patients, you should never expect that those patients, after staying in the ITU or having nitric oxide, the PA pressure will drop from 70, 80 down to 50 or 60. Never. Hardly. They will drop by 10, 20, sometimes 25 millimeter mercury drop, and they remain stable without clinical manifestation. That's what you need to do. And as long as you can achieve this with your medications, using, let's say, milrinone, amrinone, sildenafil, at the end of the day, you send this patient home. This patient will never remain in your unit forever. He will never stay there forever. And if he use the nitric oxide once in the blue moon, once in life, he will never take a nitric oxide tank with him home. because it's very expensive and there's no facility to use that. So at the end of the day, you will rely on the medications that you already have in your unit. So use the medications, try to change the doses, try to modulate the doses, try to reform your plan in a way to add more drugs, to add more vasodilators. Let's say, give them the calcium channel blocker, the Elioprot, give them the sildenafil, tadalafil, give them the diuretics, use the DABA or the dapagliflozin as well, along with maintaining good arrhythmia, some diuretics more, you'll be fine. He will not be normal, but he will be fine. He will be maintained in a stable situation. And that's what you are really, your aim, and that's what you are looking for. You know what I mean? Yes. But definitely nitric oxide is not really mandatory for all those patients. But if you have it, just use it. If you don't have, you have other alternatives that you can rely on, and definitely it will give a very, very, very good response. Okay. Yes. Thank you for the question.
Yes.
شكرا.
هنادي تمام.
شكرا.
في question then. Okay.
شكرا.
We have a question from Dr. Saeed Ahmed. When could I decide that my patient is optimized preoperatively, especially for elective cases? This is the same question of Wissam, but upside down.
Yeah, as I mentioned, but we actually we could be answered in a different way as well. Yes, definitely, you have a parameter. So as I think we're totally agree that we should never look to the pulmonary artery pressure per se, or like separately or isolated from the clinical findings. What I need you to check is, first of all, the other parameters, including the right ventricular dysfunction. If the patient having any congested neck veins, if you have a lower limb edema, pulmonary edemas, any type of desaturation, okay? If the patient is desaturated, if the patient is having a very quiet frequent syncopal attacks, anginas, this patient is not optimized, okay? And if the patient start really to have stable pulmonary artery pressure, so rather than being, I mean, our target here is not really to normalize the pulmonary artery pressure, as I mentioned. You need just to keep it steady as you can, steady as it is, okay? So if it remains for 1 week or 2 weeks with the same pressure gradient, the same mean gradient, and there is no worsening of the other parameters, this patient is very well optimized, and he can go for the surgery, but with adequate monitoring, post-operative ITU, with expectation of this patient might need really a very long stay in the ITU or in the ICU or the critical care. Take your consent the patient, explain everything for the patient, tell them that actually he's in risk of having a post-operative ventilation for a long time and other also maneuvers, and then you can proceed with the procedure. But at the end of the day, you should do that. You should do the surgery. I mean, if the patient has a hip surgery, for instance, and he needs to do a hip replacement for any reason, and you will never keep him or die with his hip because he's not having improvement for the pulmonary artery pressure. At the end of the day, you need to take him to the theater. But what we need to do is optimize him, and the optimization means there is no other comorbidity, there is no right ventricular dysfunction, there is no right side heart failure, there is no left ventricular heart failure, no arrhythmias. He's taking medications for a long time, and then this patient could be considered this will reach the highest point of optimization. And another thing, actually, if you allow me, Dr. Safa, try to involve. Don't be the one-man show, or being like a single man on the deck. Okay, try to involve the other services as well. Try to speak with the cardiologist. Tell the cardiologist, are you sure that this is actually the maximum point of optimization and no way to optimize him more? If he said yes, that's it. You have a document now, you have an evidence now, and then no one will blame you for that. You know what I mean? Also involve the ITU about your facility, about the accessibility of the maneuvers. So now at the end of the day, we need to keep ourselves very safe. Okay, we don't want to take a stress because we are human beings. We don't want to have a stress. Okay, at the same time, we need to keep the patient safe as well. So we try to balance the things together. So involving the other service is really very important.
Yes.
in a multidisciplinary manner.
Multidisciplinary team. I am preparing it to mention it. That is a case of multidisciplinary team, anesthesiologist, intensivist, cardiologist, anyone passing from outside the OR should play with us. I now suppose that pulmonary hypertension is like playing with wolf, and so you should have
exactly
many weapons.
Playing with the lions.
Yeah, yeah. We have a question also from Dr. Muhammad. Is nitroglycerin or nitroprusside are out of pulmonary hypertension management?
No, it's still there. Still there. You can use it. Yeah. Yes. But well, I mean, it could be very beneficial to rely more on the milrinone rather than the nitroglycerin or nitroprusside. But definitely, I agree with you. We could use, if you don't have a facility to have the milrinone or amrinone, you can take the GTN as a pulmonary vasodilator, although that might really cause some systemic drop in the blood pressure as well. But still, if you can tailor, the dose according to the effect, you might really have some sort of treatment as well for that. But by the way, the nitroglycerin, the GTN on nitroglycerin and the nitroprusside is considered as a sources for the nitric oxide itself, because it's been converted in the endothelium into a nitric oxide molecules. So it's the intravenous modality for the inhaled nitric oxide. Yeah, I agree with you.
Yes. Yes. The same question Wissam asked also is, during regional anesthesia, if hypotension occurred, which is better fluid or vasopressor to start with?
What else rather than the vasopressor?
The fluid and or vasopressor.
Okay. Yeah. Well, don't overload him with fluid. Start with the vasopressor. Yeah, exactly. That's a good question, by the way. So it's really very tricky here. Rather than starting the fluid, well, remember that this patient actually might be definitely very dehydrated, but also we don't want to increase the preload with those patients. And at the same time, we don't need to keep him dry as well. But I think if the hypotension occurs, probably you should really consider starting the vasopressor earlier than starting the fluid. And that's the reason why we rely on the pulse contour analysis in order to tailor our fluids. We don't want to overload him with the fluids. So any increase in the preload will really goes to the lung, which is already, as I mentioned, it is a low volume, high pressure circuit. So it might really cause more aggravation for the pulmonary artery blood pressure. Yeah.
I know that we are more than 2 hours and we do a lot of stress about you.
No, I'm fine. I'm totally fine. I'm happy with the questions. Actually, I'm happy with getting more from the floor as well. That actually reflects that the people actually started really to interact, and I'm very happy actually to give them all what they are looking for. Yeah,
thank you.
A pleasure always.
Anyone from the floor have a question? If I forget someone, if all the questions are completed, so we have now to shift to Dr. Muwaffaq and our group from our beloved country, Syria. Dr. Muwaffaq.
دكتور موفق.
دكتور موفق حضرتك موجود؟ unmute yourself دكتور موفق.
السلام عليكم. أنا موجود معكم، لكن أنا عندي عملية أبندكس، الحمد لله يعني الأمور جيدة الحمد لله.
الحمد لله. إحنا كنا لو حضرتك كنت حابب تسأل أي حاجة إحنا تحت أمر حضرتك.
والله حضرت حوالي 40% من المحاضرة، الحمد لله كانت محاضرة جيدة جدا ومفيدة وأنا كثير استمتعت فيها، وشكرا دكتور هيثم وشكرا لك دكتورة صفاء وإن شاء الله دائما نستمتع معكم بالمحاضرات بإذن الله.
إن شاء الله إن شاء الله إن شاء
الله.
الله.
لكم.
أهلا وسهلا.
Anyone from the floor I missed his question or her question? Anyone have any comment? Yes, alhamdulillah. الحمد لله. يعني جميلة جت في وشي، جزاكم الله خيرا، وأنا بأهديها لحضرتك جزاكم الله خيرا وجزيتم
الله
الجنة.
يبارك فيك.
إن شاء
الله يبارك
الله
فيك.
يجعل هذا
اللهم آمين
الوقت يا
جميعا.
رب، اللهم آمين، في ميزان حسناتك إلى يوم الدين. كل
الله
حد
يكرمك.
استفاد من المعلومة النهاردة، أولهم أنا.
الله يخليكي، الله يخليكي. That's a great
أولهم أنا.
pleasure. Always a pleasure دكتورة صفاء.
دكتور هيثم، أنا هحكي لحضرتك موقف وأنا صغيرة وأنا كنت مدرس، حصل معايا على البالمونري هايبرتنشن، وعمري في حياتي ما أنساه. إن كان عندنا بنت كانت حوالي 30 years and she is infertile and she's seeking for fertility by any way. The pulmonary blood pressure about 76 like that. She was كانت خريجة كلية تربية رياضية، ومامتها كانت the head nurse of Mansoura University. or the I don't remember exactly يعني اليونيفرستي اللي هي فيها. فهي لفت بيها كل كانت لازم تعمل diagnostic laparoscopy علشان نشوف الكوز اوف infertility اللي موجود عندها ايه.
تمام.
فهي لفت الدنيا كلها علشان حد يعملها، فمحدش راضي، محدش راضي. فهي قالت كلمة كانت في منتهى الإنسانية، فقالت لا، أنا هموت وأنا بخلف أو بعمل عملية عشان أخلف قبل ما أحسن ما أعيش أرض بور. Exactly. This is the problem بتاعتها، إنها كانت طول الوقت. حضرتك تعرف إن في الكالتشر بتاعتنا إن الست لازم تخلف، يعني ولو ما كانتش كده
طبعا
أرض بور. هي برضو هي معظم النساء يعني ولدنا ليكونوا أمهات في الأول وفي الآخر. ده الجريت ميشن بتاعتهم إن هم يبقوا أمهات. فاحنا كنا بنقول للأمها إن هي ممكن تو بي دايد على الترابيزة، إنها مش عارفة. قالت خلاص، هي اللي بدت الريسك كونسنت بنفسها، وهي بفضل الله سبحانه وتعالى دخلت تعمل. واحنا كنا ايامها ما كانش فيه جود مونيتورنج ولا اي حاجه خالص. ودخلت عملت دايجنوستيك لاباروسكوبي، وكان مش عارفه عندها حاجه، عملوا لها دريلنج كده في البوليسيستيك اوفري. وبعدها يعني ما شاء الله راحت حملت بقى وعملت IVF ومش عارف ايه، ورجعت بقى المكان اللي هي كانت فيه. فانا عمري في حياتي ما هنساها البنت دي، لان هي كانت ريسكي جدا جدا. انا اصلا مانيش فاكره طبعا انا عملت ايه، بس هو تقريبا النترونال هو اللي كان جنبي، واخد بال حضرتك. وقعدت برضو زي ما بقول حضرتك بلاينج ويز لاينز كده.
exactly.
وماسكه التليفون فاتحاه عشان اكلم اي حد يلحقني اول ما يحصل اي مشكله. وبس خلاص كنا لسه في الظلمات يعني. ده حقيقي.
لا بس دي بقى ومن احياها فكانما احيا الناس جميعا. يعني حضرتك قبلتي الحاله واخدتي الريسك ودخلتيها وعملت هي العمليه وبقى عندها حياه وخلفت حياه بعدها. فهي دي النقطه. and that's the reason why انا بقول للناس، يعني مش بقول للناس، انا بتعلم، انا لسه بتعلم يعني
ربنا يكرمك، ربنا يكرمك.
يعني مش هقول ان انا يعني، بس انا اقصد what I believe يعني. And as long as you can deal with the things in a proper way, why don't you try to take the chance? I mean, just to try. I mean, not to try. As long as you have an appropriate knowledge, you have an appropriate experience, you have an appropriate monitoring, good preparation, good pre-operative assessment, good peri-operative management. You involve the right thing. Definitely, the patient will survive. Rather than انك انت in someone you can cancel the case, postpone the case, delay the case, and finally the patient will die waiting for his procedure.
Yes,
I mean, this is the difference.
Yes.
Okay.
We have some people sometimes thinking about to postpone the malignant patient, the cancer patient, because their hemoglobin is 9.
No,
so
this is really waste of time. This is really waste of time.
Yes.
There's no sense. This is no sense.
Yes.
There's no sense. I don't want to say that it. I mean, this is actually playing with life. Playing with life. I mean, playing with their destiny. I mean, those patients really in need, being the patient. I mean, being keeping the patient waiting for the procedure for a long time. He's really concerned. He's concerned about his family. He's concerned about everything. And at the end of the day, if you give him the opportunity actually to be very well treated and have a good service, intraoperative and post-operatively, definitely you save his life. Yeah. Save his time and his life as well. Yeah.
As you said, yes, many times you said time is brain, time is heart, time is tissue, etc. And Yasser Tobl said sometimes, he said one word which is a very valuable word. The patient is not a number, he's a human being, have a family. Yes.
Exactly. Exactly. Yes. Yes. Definitely. Absolutely. Absolutely. Yes. Yes. Definitely.
Yes. يعني الحقيقة يعني طبعا يعني مش هيبقى عندي كلام طبعا هعرف أقوله هنا، لازم الكلام كله يقف، وأنحني لحضرتك على يعني هذا الكم الهائل من المعلومات. بجد بجد أنا أول المستفيدين، ربنا إن شاء الله يجعله في ميزان حضرتك وما يحرمناش منك أبدا 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 يا رب.
الله يبارك فيك.
أبدا يا رب.
الله يبارك فيك.
ودايما حضرتك by your fruitful and valuable contribution معانا وبتساندنا، وانت الباك بون بتاعتنا، واحنا عارفين ان احنا ورانا رجال كلهم شهامة ومروءة ويقدمون العلم. ربنا يكرمك.
Always a pleasure, Dr. Safa. You are a role model. You are such a role model in your in your efforts. You're a role model in organizing this thing, keeping everybody aware about knowledge. Give them opportunity actually to attend. Give them the opportunity to keep people like us actually could really provoke more efforts in order just to conduct their experience, their knowledge, and share the ideas. Personally, I learned from the floor. I learned from the question. Apart from actually doing the presentation or like presenting the lecture, but I learned from them as well. And that's every time. And next time I will really go with the pulmonary hypertension. I might really add some of those really points, and but be very helpful. So thank you so much for you and for all the attendees for their time, for giving to donating their time. Actually, donated their time from their family and from their work or from their leisure time. So thank you so much for attending. Really, it's a very great, really time I spent with you over this weekend. And thank you so much, Dr. Safa. Always a pleasure to be with you and always really learn from you and from everyone. Thank you so much for this opportunity and for inviting me for this really lovely meeting. Thank you so much.
Thank you for all the greeting and appreciation for you, Mr. Professor Haitham Al Jamil, for your time, for your effort, for your support, and thank you. And we are seeking for more opportunities to sit beside you, sit in between your hands and learn more and more. Thank you.
Thank you so much. A pleasure. Always a pleasure, Dr. Safa. Always a pleasure.
Thank you.
Thank you so much.
Goodbye.
Bye, Dr.
All the best.
Assalamu alaikum. Shukran.